I will be presenting, up to my knowledge, the largest European series of robot-assisted trans-axillary thyroidectomy as part of the global assessment of this procedure. I have nothing to disclose. In the era of minimal access surgery, minimal access thyroid surgery has been gaining increasing popularity, especially that the largest proportion of patients are young women, a subset of whom may be equally concerned with cosmetic and therapeutic outcomes. Minimal access thyroid procedures can be broadly classified into purely endoscopic procedures, partly endoscopic procedures, and non-endoscopic mini-incision procedures. Purely endoscopic procedures can be regarded as remote access procedures that offer patients a thyroid surgery free of a neck scar. One way to reach the thyroid compartment is through the axilla, and initially, trans-axillary thyroid surgery was performed using conventional endoscopic instruments. Later on, in South Korea, in 2009, robot-assisted trans-axillary thyroidectomy was described. This seemed to be an appealing option, not only to patients to whom it offers a thyroid surgery free of a neck scar, but also to surgeons to whom it offers improved dexterity and ergonomics compared to its conventional endoscopic counterpart. However, the favorable cosmetic outcomes and technical advantages of any surgical procedure should be weighed against its safety and radicality in the context of operating time and cost. Literature has demonstrated the comparability of RATTs to conventional open thyroidectomy in terms of safety and effectiveness, but at a significantly higher cost and longer operative time. These factors contributed to the procedure losing its popularity in North America. Add to that the procedure being associated with unprecedented complications that do not have a conventional analog. And these can be broadly classified into experience-related complications, which include injury to great vessels at the thoracic outlet, as well as a higher risk of aerodigestive injuries. The second class would be complications inherent to the procedure itself, such as stretch injury to the brachial plexus related to positioning the patient, flap paresthesia and or fibrosis, the possible adverse impact that the incision at the tail of the breast might have on future mammograms or the accuracy of sentinel node mapping, and lastly, seeding along the surgical axis, a complication that we have reported, and this case was referred to us. Other factors include people being worried about surgical incompleteness when it comes to remote access procedures. Some have even demonstrated that remote access procedures that offer patients a thyroid surgery free of a neck scar might not be superior in terms of patient satisfaction than other procedures that offer a transcervical access, such as MIVAT. And this is what led Professor Du to say, for now, neck incisions are here to stay. Let's sum up things. So, in Asia, it is popular. In North America, it's losing popularity. What about Europe? In a 5-year period, we operated 257 cases, the overwhelming majority of which were females, and this reflects their greater concern with cosmesis and their suitability for the operation because of their smaller body habitus. We excluded those who did not have a virgin neck, those with Graves' disease and high-risk cancer. Notice among the selection criteria that patients with benign nodules up to 6 centimeters in size were selected, and this is not inconcordant with the ATA or the American Thyroid Association statement on remote access surgery. The vast majority of our cases were non-cancerous. The 20% cancers we performed were all low-risk papillary thyroid carcinomas. the choice of surgery was concordant with the most recent clinical practice guidelines. This table summarizes our results. Let us highlight some points. We have demonstrated that in terms of operative time was significantly prolonged compared to the operative time of conventional open thyroidectomy at our center. And this has an adverse impact on both cost and the number of cases that you can perform per day in a high volume center. Regarding hospital stay, the overwhelming majority were discharged on the second post-operative day. As for post-operative complications, these were comparable to conventional open thyroidectomy. Even when you have a look at post-operative pain, you may assume that the greater dissection required to reach the thyroid compartment from the axilla would result in a greater post-operative pain, but in an ironic twist, this was not the case in our series. 3 hematomas developed, only 1 required reoperative surgery, and this was performed through the same axis. As for unprecedented complications, we had a case of tracheal injury, and this was probably attributed to the inactive blade of the harmonic scalpel. Conversion was also required in one case because we have misidentified a case of papillary thyroid cancer as being low risk. Intraoperatively, we found local invasion, so we converted to a transcervical procedure, abiding to the fundamental oncologic principle that states local control is paramount, and in order to do that, a direct access is required. So, to conclude, we think that robot-assisted trans-axillary thyroid surgery is a viable treatment option or an acceptable treatment option. Probably the popularity of all minimal access thyroid surgeries arises from the contemporary endocrine surgeons' need to offer patients a surgical approach that is tailored to their concerns and desires without compromising the primary objective of surgery, which is safety and effectiveness. This means that you need to be very selective in order to have a good success when it comes to effectiveness and safety. Thank you very much.